I'd like to invite Dr. Johari. We should be talking on managing hypoglycemia, prevention and treatment strategies. Dr. Johari, she's practiced as a consultant diabetologist in Mumbai for 3 years, delivered many scientific sessions on diabetes and related topics, and she is honored as Fellow of Diabetes in India in 2017. Total experience 11 years in the field of diabetes, currently managing medical quality and regulatory affairs at Abbott Diabetes Care. The floor is yours, ma'am.
Thank you so much for the warm welcome. So just to start by saying that this is a little slightly older slide, but my current CV basically says that I practice diabetes and metabolic disease based out of Mumbai. Yes, I've been in the pharma space for quite some time, and now it's been like 15-17 years in the era of diabetes that I have been functional as pharma. I have launched a lot of drugs, and now I'm working as independent practitioner. So I think the CV just did not come in as updated. Well, important fact here is that I'm happy to be here to talk about a topic which is very, very common and very, very important for each of us as a practitioner. So first of all, let me thank Dr. Jyoti, Dr. Gopika and the entire team for setting this up meticulously. And majorly, this is my current CV. Majorly, we're going to talk about, we heard Dr. Shruti talking about what are the practice techniques for insulin, very well covered. And of course, Dr. Ritu, brilliantly telling us where to add which type of insulin. Because, just adding insulin is not the end of the day. And of course, when insulin comes in, a lot of patients will come and tell you that, I'm using insulin, but my sugars are still not there. I still don't have the optimal control. And that is where we should not get worried or scared of the insulin. What is important is to remember we are the physicians or the diabetes treating doctors there, and we need to help these patients to get optimal control even while they are on insulin. Because if they need insulin, no matter how much ever you may try to give OADs, they may not respond adequately. So we need to understand what is this fear of hypoglycemia and how do we ensure that these patients don't get hypoglycemia and thereby are able to prevent these kind of situations. So what is hypoglycemia? We all know hypoglycemia is basically when the blood glucose levels are falling below 70 milligrams per dl. But as the ADA says, there are different levels. There are two levels which are measurable and one, of course, we go by directly the symptomatology. Okay, now when we talk about the measurable levels, as ADA has set up, less than 70, more than 54 milligrams per dl glucose is the level 1. Level 2 is when the glucose has fallen beyond 54 or below 54 and patient has symptoms. And of course, level 3 is when you're not looking at the glucose alone, you're looking at the altered mental and physical functioning of the patient. Looking at the incidence, hypoglycemia is one of the most underestimated or overrated. Why I say two different words is one, because a lot of times patients will not have the corroborative evidence. So we'll come on to that. But if you look at the documented evidence, it says 50% of patients with type 2 DM will have hypoglycemia. And globally the numbers are not very different. 45% patients have had mild to moderate hypoglycemia even in type 2. And if you look at severe hypoglycemias, which means requiring assistance, requiring hospitalization and treatment, those could be 6% of type 2s, a global number. So which is a big number when we see the overall population. So why worry about hypoglycemia? It's just, like you just take sugar and everything is okay. But no, that's not the end of it. What happens is our multiple organs throughout the body need, like oxygen, even glucose for a primary functioning. So if this glucose is not going to be available even for a bit of a second, there is going to be a lot of change in the entire functioning of the body. And that is where if you look at the brain or the cardiovascular or musculoskeletal systems, these kind of issues will come up. For example, you can have blackouts, you can have seizures, ranging to coma, cognitive dysfunction, psychological effects that the patient is showing because of chronic hypoglycemias, especially with elder age dementia. If you look at cardiovascular, most of the hypoglycemia related silent MIs happen in sleep, and we all read about it in papers that that is going up. That is just because of hypoglycemias that are taking patients off for death in bed. Then falls, accidents, somebody can't see, blurring of vision, sudden fallout, and then fractures, and then related expenditures in the hospital and morbidities. We know about the symptoms, we know Whipple's triad, how it was, put up together, that we said, okay, when there are symptoms happening, person feels that he's seeing the world upside down, and then, you kind of feel the entire jiggy, shaky kind of feeling, and then you get, finally, when you eat something sweet, you feel great. So that is known as the Whipple's triad of the symptomatology. But looking at what exactly are the different classifications of clinically of this hypoglycemia. So patients will come to you with 5 different types. One is, of course, severe hypoglycemia, where you know that the patient has been brought by somebody. Patient hasn't walked in. The patient has needed assistance either by family, caregivers, or neighbors, and even by your staff in your clinic. Okay, where you have the sugar levels, you know that there is confirmed hypoglycemia, and you can see the symptoms very clearly. Second is documented symptomatic hypoglycemia. So patient has come to you, patient is telling you by himself or herself that I had these symptoms, I checked, and this is the level that I had. So you have documentation, you have hypoglycemia, it's confirmed. Then there is asymptomatic hypoglycemia. Now asymptomatic is most of the times unawareness, and this is where the underreporting happens. So what does this mean? This means that the brain is not triggering the body to show impact or fall of sugar. And that is where we do not get symptoms of hypoglycemia. So patient will be like, no, I was fine, I didn't get any symptoms, I'm absolutely okay, why do you think I was going low? No, I did not go low. And then there is probable symptomatic hypoglycemia. Again, the word tells it all. Probable, we don't have documentation. Patient has not tested, but patient says, I took your medicine, I got sweaty, my sugar went low, I had to take sugar, I felt better. Now taking sugar, let's understand, even you and me, if we are given chocolates, we are given ice creams, we feel better. That is the normal response to sugar for every simple human being. And that is why we need to train patients that just if you are correcting yourself or feeling good by eating sugar doesn't mean that previously you had hypoglycemia, unless it is documented. And that is probable symptomatic hypoglycemia, which therefore must be confirmed. Lastly, there is relative hypoglycemia. Now this is a very vague term and you will hear it very less, but then it's very important because usually patients don't come up and tell us, so we need to question for it. What is relative hypoglycemia? So somebody who's been at a sugar of 300, 400, 5 months, no follow-up, okay? They come to your clinic and they are like, okay, this is their sugar report. You start them on a particular treatment. They come back to you saying, you call them in 15 days or a month, they come back to you in 3 days. I don't know, my sugar is going low. I'm feeling all the symptoms of hypoglycemia. But the sugar levels, if you check, they are at 120, 140, 160, 180, and you are perplexed. Why is the patient having symptoms? There is no hypoglycemia. Now the moment you tell the patient that this is not hypoglycemia, they will take it very negatively. So you need to explain that this is relative hypoglycemia, which means what? The patient has been used to sugar levels of something above 250 all day. And suddenly you're bringing them to 130, 140, 160, 180, whatever. So that is known as relative hypoglycemia. That is the difference that you have to explain the patient as well, that it is time which will help them to accommodate to those sugar levels. The same I think also applies to blood pressure, just for the note. Then of course we know, the pathophysiology of hypoglycemia, but here, why I have put this slide here together is that, at 80 and 70 also, there are certain steps that are happening in our body. We know counter-regulatory hormone and how it works. But what is important is that once the sugar levels start falling at 70, and if the body is not able to counter-regulate, that is where the problem comes in. At 50, you start getting palpitations, sweating, probably decreased cognition, below that aberrant behaviors or change in behaviors, probably epileptic seizure at that time, coma. And of course below that there is neuronal cell death. So you can see that there is a cognitive proper establishment of the impact that is seen. Now if you see the patient perspective, there are a lot of publications, but this one found real interest for me. And why important for us is because patients also come to us because they read. Nowadays Google is available, the next doctor before AI. Okay, so they come with a proper read, but it is important that we show them what they should read versus what they are reading. It's easy for anyone and everybody to go and write online, but important for people to know which ones are reliable sites to get their information from. Now this is one of the papers where Lemma et al. Have shown that patients with diabetes do understand that food and exercise are the most common reasons, if gone imbalanced, causing hypoglycemia. So that is the patient perspective, and you can see various other reasons also put in, where stress also comes in, and of course impaired hypoglycemia awareness is also underreported, but there. And if we look at the scientific perspective, so the various causes of hypoglycemia, it could be drugs, food, exercise, disease, habits, all of these segments. And I can have one slide on each of this, and we can actually have one session on each of this. Why? Because if you look at the drugs, we obviously know it's the glucamides, it's the sulfonylureas, the insulin, which are the common ones blamed. Yeah? So when the patient is on this, ensure that you are educating them enough that these are the things that can happen. And if there are patients who are prone, then we do not use this kind of drugs. Similarly, food, too little intake, skip delayed meals, GI upset, patient is vomiting, has a gastro upset, so then you need to change the medicine. Accordingly, exercise. If they are overdoing it, are they like really taking the medications too seriously, or are they overdosing themselves with insulin? Similarly, if you want to look out for disease, if there's no other reason for the hypoglycemia, you need to look out for other pathologies causing hypoglycemia, and of course ask for habits like alcohol as well. As per ADA recently 2024, they have also put down together a very beautiful paper. You can go through this of how you want to assess hypoglycemia, its severity, and the basic risk factors, so that you can educate the patients accordingly. So I'll go a little fast on the treatment, but basically we all know that as per the severity, we need to ensure that we're treating the patients. For example, if the patient has come to you with severe hypoglycemia, like I said, requiring assistance, obviously requiring hospitalization, so you know that you have to treat with IV dextrose. You'll not wait for them to eat biscuits or something like that. Similarly, if this conscious patient, you obviously want a readily absorbable carbohydrate that they can eat and quickly probably get okay. Similarly, if the patients are not able to take any oral agents, any oral intake, then you can give them glucagon, again oral or injectable, we can debate about that. And finally, if the patient is more awake, then you start giving them complex carbohydrate sources so that eventually their sugars have risen well and they get back to their normal cognition. So again, like I said, alert patient, look at the mental status, give a fast-acting carbohydrate, look at sugars that can effectively manage hypoglycemia, teach them to keep those handy. When there are glucose tablets somewhere available, ask them to keep those. If unconscious patient, of course, like I said, IV dextrose, glucagon, various options are available, India, abroad. We can get to that in another session. Talking about non-pharmacological hypoglycemia management, of course, we can have patient education, which is the tombstone or the cornerstone of every particular patient education for diabetes. Now, just for the record, when we want to prevent hypoglycemia, most important thing is look at the precipitating factor. Why is the hypoglycemia even happening? If we try to address that precipitating factor, then it's easier for us to prevent the future falls. So, patient education and empowerment, very important. Monitoring, very important. It could be SMVG, which is self-monitoring of blood glucose. Most of the patients have these at home. They're just probably not making the right use of it. So you get that. Then you can also do continuous glucose monitoring. I'll just show you quickly one slide where it shows how it helps. You can have flexible insulin regimens, like Dr. Vipul said. If you're using it right, you will never get hypoglycemia with the good insulins. Then there is, of course, timely professional help is very important, which patients probably don't do. So let them know that how important is it to have their sugars under control, and for the same have professional updates from time to time. Similarly, have individualized glycemic goals. Do not see what my neighbor is having, what is his sugar, what is her sugar, oh, I'm better than her. No, that is not it. You need individualized goals. And similarly, KYG, which is know your glucose. So have tips to manage hypoglycemia handy. Now quickly, 2-3 evidences. For example, why patient education is critical. Now this I've just put in here, there are various injectable pens that you will see. Now here, for example, the prescription is injection Tresiva 10 units, okay? 10 units can be given via 2 different pens, one with a U100 and one with a U200. I'm sure you all know what is a U100 and 200. In the U100 pen or cartridge, you actually have 100 units per ml, whereas on the contrary, the other one has 200 units per ml. So imagine if the 10 units of 100 is expected, and if you give 200, it's overdosing the double. Whereas if you're expecting the 200 to be given and you're giving 100, it's underdosing. And this is where exactly, even if your patients are educated or uneducated, you need to train them of how to take the specific insulin that has been expected for them to take. Then if you talk about the right selection of drugs, this is a paper recently published in the International Journal of Clinical Practice, where it is said that when we have Ramadan, in Ramadan it was seen that obviously patients are not going to eat the kind or quantity of food that they regularly eat. So how do we ensure that the hypoglycemia is not a part and parcel of their life? So if we replace the sulfonylurea with a DPP-4 inhibitor, sitagliptin was the study molecule here, then they saw that actually they could reduce the asymptomatic hypoglycemic events to half. You can see 92 events with sulfonylurea versus 43 events with a sitagliptin. And therefore, very important that we choose the right drug at that time. Finally, coming to CGM. Now, like I was saying, how many of you use CGM? Okay, very few hands. But try to use more, okay? Why? Now if you look at this traditional method, you may have seen this slide many a times, it's a very well published paper. But the point here is, if you are doing SMBG, or if your patients are doing SMBG, they are still missing out highs and lows, which is then captured on CGMS 24/7 even while you are sleeping. Yeah, and here there are two studies differently that I'm talking about where hypoglycemic symptoms or episodes that were missed were actually picked up on CGM. So 63% with type 1 diabetes were recognized on CGM, which were otherwise undetected, 47% with type 2. And similarly, another paper talking 83% with type 2. So imagine now, just see the numbers, the incidence of hypoglycemia, then this uncovered by the CGM. So the role of continuous glucose monitoring in ensuring that your diabetes and your hypoglycemia are covered. So lastly, my summary slide would say that, hypoglycemia is definitely a very common occurrence. You have a patient with diabetes, at least 2 points in his lifetime, he's going to have or she's going to have hypoglycemia. So probability of it obviously increases whenever you're reaching closer to the A1C goal, because that's, you are sure that how much to go ahead and how much not to. And then identifying the precipitating factor is always going to help you to prevent future events of hypoglycemia. Main cornerstone remains educating the patient, whether it is about how to manage, what insulin they are taking, how to see the doctor, and in special cases you need to also educate the caregivers. And finally, the goal is that by reducing the hypoglycemia, the frequency as well as severity, you basically want to improve their quality of life and the health outcomes. So with that, thank you so much for patient listening.
Thank you, Dr. Ritu. It was so great.